No.
Yay, there
Oh,
we go.
good.
Okay, we got it.
Okay. We are recording. We're recording right now. Okay.
Yeah, and all the other people will be much happier.
Well, okay, so we'll be working through number 2, and I'll just have to go back and say something about number 1. So, and I'll start my video here. Okay.
Oh, and I want to know if my number 2 looks okay. So
Okay.
you guys could just look at it and see what I need to add.
Okay.
Okay, can you see this document?
Not yet.
Okay.
No,
That
Now
one?
we can.
Yes, now we are.
Okay, so I have the third ventricle. The I should I put more there? The cerebral aqueduct through midbrain.
Oh, yes, you do want to put, yeah. Oh, no, you have it just right. Because you have it going into the third ventricle. You have it and then you have it going through the aqueduct of Sylvius. Then you have it going through the fourth ventricle. Then you have it draining into the subarachnoid space via the foramina of Luschka and the foramen of Magendie. And that's great. And then you have it. And you have it in the subarachnoid space, you mentioned that, and then the arachnoid granulations, and then you just want to get it into the protruding into the triangular shaped. Is that where you're going to say?
Well, yeah, because you said something interesting about that blood vessel being triangular, so I like that kind of stuff.
Well, I put that as a kind of in parentheses or something because the main event is it's the arachnoid granulations protruding into the mid-sagittal sinus.
Okay, so I need to write that after this.
No, I put it right into the, instead of blood vessel, put the mid-sagittal sinus.
Into the mid-sagittal sinus.
Yeah.
Sagittal sinus.
And sagittal, I think, is 2 G's.
Geez.
Yeah, 2 G's. Sorry.
Oh, that's okay. No, it still doesn't look right.
Maybe it's
There it is. It's 2 T's.
2 T's. Okay.
2 T's.
2 T's and 2 T's. And
The
then if you
computer.
want to put it after that, if you want to put it, it is a detail because functionally we're not interpreting it in any way, but anatomically it is a triangularly shaped blood vessel or vein.
The mid-sagittal sinus is triangular shaped.
Uh-huh. Yeah, in cross section. In cross section. It's you know, it goes straight from here across the top, across your skull, on the inside, obviously, to the back of your head, and then divides into 2 lateral sinuses. But if you cut that thing in cross section, instead of like most veins are round and, you know, like cutting a hose, this is like cutting a triangle.
Fascinating.
Oh,
I had a
Triangularly shaped.
question.
Say, somebody asked a question.
Oh yeah, I had a question because in the notes I wrote, there's in between the transverse sinus to the jugular vein that there's the sigmoid sinus.
Oh yes, the sigmoid.
Yeah.
Let me. I think it's in the slide. Let me go to the slide. Share screen. Okay, I have to stop sharing. Oh, you know, Renate, I can't share a screen unless.
Oh, I have to stop sharing.
Yeah. Okay. Let me.
There we go.
Okay, so let me go to the appropriate slide here that refers to the points. Okay. Okay, I'm getting there. Okay, I'm going to refer you to slide 21. Am I sharing the screen? No,
No.
not yet.
but I will now. Okay, this is slide number 21.
Okay.
Okay, and this shows us. Okay, so here, I don't know why my little thing is not. Why is this doing this? You see the thing oh, I think if I go big, it's okay. Okay, yeah, that's good. Okay, so here's our superior sagittal sinus. Are you all oriented? Here's the front of the skull, back of the skull. Here's a superior sagittal sinus starting right about in between the eyes and going up, across. And if we cut that in a cross section, you know, here, we'd see it shaped like a triangle, but it's functioning like exactly like a vein, comes back to the back of the head, and it divides into a right and a left transverse sinus. So there it is. So that would be the one that comes next.
Okay, so it's not lateral next?
Not yet.
Okay,
Well, no, it's right transverse sinus.
okay.
That might be called the lateral sinus. I'm not sure of that, but it might be lateral sinus.
Okay.
Okay, and then didn't mean to go. Okay, so the right transverse sinus, and then the sigmoid sinus. And then it drops out through the jugular foramen, and that's the jugular, forget the foramen. It drops in, it forms the jugular vein. Okay, so you good?
Yeah.
Ooh, I have a question.
And Renate, do you have that?
Yes, I'm gonna type all that right now.
Okay,
Okay.
okay, then who was that, Riley?
It was Melanie.
Okay.
Is the mid-sagittal sinus different than the superior sagittal sinus?
You know
I
what?
mean, the superior, did I say that right?
Yes, no, you said that exactly right. It's the superior sagittal sinus.
Okay, so
Yeah.
is the mid-sagittal the same thing?
I don't know that it is. I think I shouldn't have been calling it that. It might be, and that's might be where my brain is taking that from, is from an alternative naming of it.
Okay,
But,
okay,
but I have it in my slide as superior sagittal sinus.
okay.
I think I do. Well, I do here. And I think if we go back to where I first reference it, and here it's labeled. Now this is a cross section. Oh, here you can see the triangularity of it. It's a cross section through the superior sagittal sinus. And I'm going backwards. There, it's not there, so forget it. Forget that one. And it is here. So every place it's in the slides, it's referred to as the superior sagittal sinus. But I think that I inadvertently called the mid-sagittal sinus, and it might actually be called that, but I'm not 100% on that. And I didn't intend to do that.
Okay, sounds good. Thank
I
you.
didn't. Yeah, I don't want to use alternative names all the time. It's just if they're highly common.
Makes sense.
Yeah. So it's not my intention. Okay. Shall I stop share on that then?
Yeah, I think we're all good.
Okay. All right. Okay. So we're kind of done with number 2, I think, because we showed where it got made, we showed where it flowed through, all the structures. We could look at the anatomy of it now in a more realistic way, because what I would call this a schematic illustration. It shows something very important, but it doesn't look like a brain. But once you know the brain, you can relate the two together very, very well. And you really, really can describe, if I just simply say, if I said, well, let's write an essay, describe how the CSF gets produced and where it flows from until it ends up back in the blood. You can do it from just that one thing we just did.
That sounds like a good medical test question. Could you see if my paper is correct, sir?
Yes, of course.
Okay,
So you're going to share.
so here we go. I just want to make sure I've got it all. So we go from third ventricle, aqueduct of Sylvius, fourth ventricle, drains into the subarachnoid space foramina via foramina Luschka 2 and foramen.
I think Magendie is actually MAG, I think. Yeah. I think
MAG, okay.
Just for my own point.
G.
Yeah. And it seems to be happy with that. Amazing.
Oh, yes, it does. It now knows it's right.
Yeah.
Okay, arachnoid granulation protruding into the mid-sagittal sinus, triangularly shaped brain, drains into the venous blood of the superior sagittal sinus. Then we go to the transverse sinus. Now, is that on both sides of the skull?
Yep.
Okay.
Mhm.
So I should write both sides?
Uh-huh.
Okay. And
Same
it
thing for the
doesn't-
sigmoids. You got two of them, and you got two of the jugulars too.
Okay, so on both sides.
Yeah.
And then jugular vein, both sides.
Yeah.
Oops. Both sides. And then finally to the heart.
Well, let's take the heart off because there's more stuff in between,
Oh, okay.
but we don't have to do that. We've got it back into the
So
blood.
the blood supply. Okay, so
We've
that's
got
it.
it in the blood. We've got it out of the cranium.
All
that's
right,
what we
so
need
I
to do.
can just,
And in general, we're not going to be labeling a whole bunch. Well, I'm not sure we're going to label any veins. There might be one or two, but in terms of understanding strokes and aphasias and everything that can go wrong, it's all about arteries.
yeah.
So we're not even going to carry that blood back to the heart. It does go back to the heart, and it's almost there, but it's not quite there.
Yeah, I have a question about blood pressure. How does our brain control blood pressure?
Oh, that's
We
well,
don't need
that's
to talk about that.
yeah, that's another subject, and we
Okay.
don't go back much into that because that's about hypothalamus. We don't go much into it, and I think the epithalamus too is involved with it. It's all part of the autonomic nervous system, and we'll never see. We will see a patient who has coincidentally autonomic nervous system issues of whatever kind, but it's always going to be coincidental. It's never going to be their primary thing. We're there to see them because they've got something wrong with their autonomic nervous system. No.
Yeah, okay. Thank you.
You'll over the course of years, you'll see patients with every coincidental thing that you could think of. Because you can have a stroke and have Broca's aphasia, plus you had this other thing, or you get this other thing.
Sure.
So you'll encounter everything, and it does affect what we do, in the sense that you can't. Sometimes people are too sick to participate, or they're
Yeah.
going to die for another reason. It's not what we're seeing them for. So you need to plan accordingly. But there's no way we can begin the process of undertaking to understand all those things. And you might only encounter a certain thing once ever or never, so we're not even trying to learn those things.
Got it. Yeah, our brains would explode.
Yeah, and plus we probably wouldn't spend enough time on what we really do need to know.
Exactly.
We're so busy trying to learn everything. Yeah. Okay, so that's it. The only thing that I might do a little differently,
Mhm.
you've done it very clearly, but when you say here, drains into the subarachnoid space. It's clear, but somehow somebody other than us four reading that may not pay proper attention to the significance of the subarachnoid space.
Oh,
And so I'm thinking that if you said from the fourth ventricle, it goes through the foramina of Luschke and foramen of Magendie, and then another one of your lines, where's it go to? Subarachnoid space. So subarachnoid space gets its own line.
okay, got it.
Yeah.
Yeah, I'll do
You've
that
done
right
it.
now.
You've done it with words, but it might make more of a impression if it has its own line.
Got it. I'm gonna cut that and make the line right there. Right there. Control V. And then I'm gonna add one of these. There we go. Oh, did I not put the words in correctly?
Oh, let's see.
Okay, so I should put fourth ventricle
And then it goes through you could say through, I guess. I don't know.
through. Okay,
It goes through the foramina of Luschke and foramen of Magendie. And then it goes into the subarachnoid space. Yeah.
okay.
I think that's perfect.
Oh, great, because I'll probably share this with everybody.
Oh, that'd be awesome.
Oh, yes. Well, I'll be giving it to you, sir, and then you can share it with the class.
Okay.
That's why I want to make sure it's right.
Oh, it's right.
And I don't know how to make those little upside down arrows.
No, that's fine. That's fine. Now, let me just ask you a question. Considering the importance of that schematic, how long would it take you to learn how to take out a piece of paper and just write that down?
I think it would be pretty easy because I'm gonna make a mnemonic.
Yeah, I think about 10 minutes and you'd have
Yeah,
it.
not too long, no.
No, it's,
Yeah, now that I know it,
yeah, because
I
it's
just
so
need to look at
concrete.
it a couple
So
times.
concrete, and it's, you know, you kind of know all the terms and you kind of know that stuff anyway.
Right,
Already, you do, because you've heard it, you've studied it, but this makes it very, I don't know, just,
It just like breaks it down a lot
so
easier.
linear.
yes,
Yeah, it's linear for sure.
very linear, very linear.
It's a nice way to sum up like the PowerPoint slides,
Yeah.
and so
Yeah.
study it in a nice simplified way.
That's right. So what
Right.
we've done is we've taken a whole bunch of words, and your book does it, I don't know how many pages, several pages, I think.
Several.
Yeah, and it says the same thing. You know, if you go back, you learn this and you go back and you read the book and you say, well, of course, yeah, totally see it now. But this boils it down to the essence of it. And yet it's only, you know, a few words on half a page.
Yeah, much better.
Mhm.
It just seems so huge and now it just seems so. Da, 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 da.
Yeah.
Just follow the da, da, that's.
Yes, we reduced, I don't remember how many pages it is, but it's a few. We reduced a bunch of words. We can agree to that. It's a few pages with a bunch of words, and it's all there. There it is. And then let's take a quick look at the illustrations.
Okay.
I mean, the anatomically accurate ones, or they're more anatomically accurate, and see how these things relate. Just make sure we can find them all and label them all. Okay, so you're saving that and you're going to share it. You'll
Oh,
send it?
yes, I'm
Okay,
gonna send it
awesome.
to you.
Okay, beautiful. And then I think, am I sharing a screen right now? I think you are.
Well,
Oh.
I'm gonna stop sharing there.
Okay,
Here we
okay.
go.
Thank you.
Thank
So
you.
now I'm going to share my slides again. And we're going to kind of go backwards to where we start this system.
All right, okay.
Okay. Well, yeah, okay, so not that one, but starting here. Let me just try to mention the spaces that I know we've mentioned. So this space between the skull and the brain is the subarachnoid space, so that obviously we want to know that, and that's a little more realistic depiction. It's still kind of schematic, but you can see here that it goes down and bays all the way around the spinal cord. Here we see the superior sagittal sinus
Mhm.
right there, and here we see an arachnoid granulation. Here we see a lateral ventricle, and here we see choroid plexus, and they're depicting here a foramen of Monro. And here's a third ventricle. They are depicting here a cerebral aqueduct and a fourth ventricle. Notice that there's choroid plexus in all of them. Okay, and here we see a foramen of Luschka. I guess that's supposed to be a foramen. They don't really show a foramen of Magendie, and they don't label it here either, but that's what it is. Okay, so I think that's about all we see here. Let me go to the next one. Okay, all right. Here we see a different kind of depiction of it.
Right.
Two lateral ventricles. We're looking at one. Here is a right lateral ventricle, and here you can see the choroid plexus in the third ventricle. Here's a third. Here's a foramen of Monro. Here is some choroid plexus in the lateral ventricle, sort of wraps around the whole thing. But you can see it's not in the whole, it's not in the entire thing. It's in part of it. It's kind of a strip. And here you see a more realistic depiction of the cerebral aqueduct. Here they call it the aqueduct of Sylvius. Here's a fourth ventricle with another little strip of choroid plexus. Here they do label a foramen of Luschka and a foramen of Magendie. And they don't show the subarachnoid space in this one at all. Then here we see a different rendition of parts of it. We see a third ventricle really well. We see a representation of a foramen of Monro. Here they called it an interventricular foramen. And here we see an aqueduct of Sylvius. This is a little bit better representation of why it's so vulnerable to a brain injury, and that is usually, I don't know the percentage, but it's more than half, significantly more than half. When there's a brain injury that affects this functioning of this system, the problem is right here. And the reason for it is because it's a very small part of the brain. It's about as big around as my thumb, with this tiny little canal that goes through it, but it must be open. Otherwise, you're going to get a block. So what happens if this closes, if this aqueduct of Sylvius closes, you're going to continue to produce CSF in the 2 lateral ventricles and the 3rd ventricle, but they have no place to go. There's only one drain at that point, and that's the aqueduct of Sylvius. So they'll just accumulate fluid and start to push the brain out from the ventricles toward the skull until the person's dead, basically. It's going to go. Like in 24 hours, they'll be dead because they have too much pressure. And the reason, that's the critical nature of this, that's why the reason it's so vulnerable is because it's going through a structure about as big as my thumb, and it's got this entire huge brain up there.
Wow.
So why, if you took the brain out of the supportive structure, it would just sort of fall over, like if you had a massive heavy flower on a little tiny stem, it wouldn't work. But the brain is in there, and it's all kind of supported by the falx cerebri, and everything is holding it in place. But if it starts to swell, which it does after injury, it will start to push it will start to cause a hernia. Do you know what a hernia is? You know, like when the the abdominal muscles have a weak spot, the intestine will start to herniate out through that weak spot, and the person will have a little lump under their skin, and that's intestine that's herniated out past the muscle. The same thing happens here. If you start to cause swelling up here, it'll herniate little parts of the temporal lobe down through a little hole that the midbrain is going through. And put
And is
pressure.
that the hydrocephalus?
Well,
is that
that's the
what
effect, that's a consequence of,
Oh, okay.
that's going to cause the hydrocephalus, because as soon as that herniation starts to take place and put pressure on the midbrain, the aqueduct of Sylvius will stop draining, and they will
Okay.
develop a hydrocephalus. And then they will go through from, potentially normal cognition to confusion, to a lot of confusion, to not knowing where they are or even who they are eventually, and then lose consciousness and then die. That's the way it would go.
Is there treatment?
Sure. Yes.
Oh,
Yeah.
good.
Yeah. We'll kind of get to that.
Okay.
great. So are you okay with the anatomy of it?
Oh, yeah.
Let's see if there's another illustration that shows us more. We looked at this. We looked at the pia mater, the subarachnoid space, the superior sagittal sinus. There it is labeled, not mid-sagittal sinus. I know I've used that more than once. I have to look that up later to see if I'm.
Is
totally-
that little gray block the sign of the granulation or the blood
That's
vein?
right. Here they label it the arachnoid villus, so the name's almost the same, but that's an arachnoid granulation. Two names for the same thing.
Oh.
Yep.
Well, that's
Okay.
the granulation. And granulation is when it turns back into blood.
Yes, so what it's doing is it's taking the fluid down here in the subarachnoid space and putting the fluid back into the blood with the other fluid and the cells. Yep,
Wow.
that's what happens. So it's doing exactly the reverse of what the choroid plexus did.
Huh.
Pretty cool system, isn't it?
Yeah, I never heard of arachnoid granulation, so it's all
And-
new to me.
And the whole purpose of it is to float the brain.
Yeah.
One, to bathe it in a friendly fluid. Salt water is very friendly fluid.
Yeah, when we heard that the brain weighs about 3 pounds, and then with the fluid it only weighs 45 grams, I was like amazed. That's a lot of weight taken off just because of the liquid that it's floating in.
Yeah,
I think 45 grams was not even an ounce or two, 3 ounces
Of fluid, right?
of brain weight, because when you put it in the fluid,
Oh,
it said,
well, I think
it said
when
that
you,
it took the weight and let it less, 45 grams.
yeah, I think probably you're talking about every kind of fluid there is in the brain, not just the CSF.
Right, so
Yeah.
it makes our brain lighter.
Yeah, like if you dried it out.
Right, if we dried
Nothing-
it out, our brain would be 3 pounds. But when it's in that fluid, it's
Wouldn't
just
be
like
much left. Yeah.
much lighter, like it has buoyancy.
Yes. Okay, so let's see if there's another. Well, we looked at this one, and this one in particular, we're looking at the superior sagittal sinus, dividing at the back of the head into a right and a left transverse sinus. What's in there? Blood. And a right and a left sigmoid sinus. Where is it? And they don't show it here, and I don't think we can see it at all, but it's draining then into the jugular foramen, which is not shown. And then the name of that thing doesn't matter. Like we learned the other foramen of the system, but here it's just a hole in the skull, and it's draining into what's important, jugular vein. So right transverse, right sigmoid sinus to jugular vein. Okay, so we got that one, and and then this one we haven't done yet. Okay, so okay, so we did number 2. You did great.
Yay.
Okay. Okay. It is 3:40. Are you okay to continue?
I have 243.
Oh, well, I meant 2:40. Yeah, 2:43. Yeah. Are you okay to continue? If
I'm
somebody
good.
I'm good.
if somebody needs to leave, we totally understand and won't think ill of you. Okay. So now let's go to number 3. Describe the results. And you all have it in front of you, or should I project it out? Do you have the number?
I have it
Okay.
in front of me.
Melanie, do you have it? And Renate,
Yeah, I just gotta
I
pull it
do.
up.
you got to find it.
Okay, I got it.
Okay, maybe, yeah, it's probably, since we want to look at this next, the screen that we're looking at anyway, right now, pretty much right now, I'll just leave it there and we'll all look at our own piece of paper here. Describe the results that would follow blockage of the aqueduct of Sylvius. Why'd I bring that one up? Because that's where it's usually going to be. Your description should include a brief description of what happens to the brain anatomically, what the signs and symptoms of such a blockage would be, what the main diagnostic tests or tests are that would show what the results would be in objective terms. And in general terms, describe the speech, language, cognitive, and swallowing signs and symptoms that would be found early in the progression of the problem. Okay, so let's start with the first one. What would be happening to the brain if there's a blockage of the aqueduct of Sylvius? And so you're just going to talk about, just in general terms, the brain, not the CT scan or, not a test result per se, but just a description of what's going to happen to that brain.
Wouldn't it start to swell?
Yes, it would start to swell, and it would show its swelling because you take the subarachnoid space that normally is around the brain, and literally it would disappear. The brain would be squeezed out against the cranium. It's supposed to be floating in the fluid, and the fluid would still be there in a sense, but the space is obliterated. You wouldn't even be able to see it on a CT scan of the brain. The brain would be touching the skull as much as it possibly could. There still would be pia, there'd be arachnoid, there'd be dura there, but there's no fluid because it's all been squeezed away by the swelling brain. Then the other thing that would swell would be the 3 ventricles themselves. Which 3 ventricles?
So the lateral ventricles and then the third ventricle?
Yep.
Okay.
Yep, but not the 4th. And then the other thing that you'd notice, and really it's just a kind of another way that what we just described shows itself, is you wouldn't see the convolutions on the surface of the brain. Because the brain would be, in order to show those, and you can actually see them on a CT scan, like if you look at this normal CT scan here, you see, here's a gyrus, and you can see it shows itself. You can draw a line around it. You go over here, well, it's still kind of there, but it's the whole brain has become flat because it's pressed up against the skull. And the radiology report would describe that as what they call effacement of the cortical gyri. The cortical gyri don't show themselves prominently because the brain is squeezed up against the skull. Okay, and then the other thing that would happen, and it's there is swelling. There is swelling, as you're saying, in a sense, because you're taking the brain such as it's normally constituted and pushing it out against the cranium. So I guess you'd call that swelling. But the brain tissue itself is not swelling, it's being compressed. It's being compressed between the skull, I can't move the skull, and the expanding 3 ventricles. Make sense?
Yeah.
Okay. So now how will that look on a CT scan? Let's see. What are the signs and symptoms of such a blockage? Let's get to that before, which kind of relates to the last part too. What do you think the first thing to be manifested would be? The first little tiny.
Would it be like mood changes or like their mental state?
It would be their mental state, and it would be
Okay.
minor confusion. I mean,
Okay.
It show itself very minor at first, like in terms of assessment. If anyone, the nurse, the physician would do this, you would do it if you were seeing them. What's your name? This person still know their name. Where are you? They probably would, if it's real minor, they're still going to know they're in the hospital. You could even probably say, what's the name of the hospital? And if it's a highly familiar hospital, like in their hometown type of thing, they'd know. But then if you say, well, how long have you been here? Now they're trying to get, because that's new information, see? Or if you said, what did you have for breakfast? That's new information. That's where we get into problems. So that's called recent memory, and it's very sensitive.
Okay.
The way we assess it is we tell them, I want you to remember these 3 words for me: wagon, robin, and blue. Okay, what were those 3 words? They'll say wagon, robin, and blue. If they can't do that, we're not even talking about recent memory. Their immediate memory is impaired. That's more severe. So we go in, we say, okay, what's your name? Say their name. So now we know long-term memory is fairly intact. Then we'll say, remember these 3 words: wagon, robin, and blue. What are they? Wagon, robin, and blue. So now we know their immediate memory is pretty intact. And then we say, I want you to remember those 3 words, because in a few minutes, I'm going to come back and I'm going to ask you again. Meanwhile, I would like you to tell me the name of this object. What's this? What's this? And we go through a bunch of stuff, or just basically testing some simple language things now. And about 15 minutes later, we'd come back and say, remember those 3 words? I ask you to remember, and if they can remember them, they have intact recent memory. That will be the first thing to go. It's very, very delicate. And you know how delicate it is, because that's what you're working on right now. In order to learn all the stuff we're talking about, you're trying to get it from immediate memory, when I just say it and you got it, so you can remember it tomorrow, or better yet, next Wednesday when you take the quiz. But once you got it, like a lot of things you got, other than your personal information, of course, you've got that in your long-term memory, but even a lot of things in speech language pathology, you had them in 242, and then you repeated them in the next course, and they're in your long-term memory, and they're pretty resilient at this point to the impact of even brain injury. Okay? So the worse it gets, then you're going to start impairing more and more of that memory, to the point where they're not even able to attend to you. They may still have their eyes open and responding by turning to stimulation and stuff, but not really attending enough to process information. to the point where they don't even respond to anything but painful stimulation. They'll get to the point where they don't, if you just go like this or you touch their arm, they don't respond. But if you cause painful stimulation, which as an SLP, I never do that really. I mean, I do unpleasant things, but what I do is just use ice cube on the earlobe. If it's not painful, but it's very stimulating, and they will respond to that. What a physician would do is they come in and they press on their sternum with their thumb real hard, and it's painful, and the patient will respond or not respond. But if they're to the point where they don't respond, then you're getting into no response to painful stimulation. The next step is their vegetative functions start conking out, like breathing. Okay, so that is the answer to signs and symptoms. And the main diagnostic test is going to be this CT scan that we're looking at. They're going to do that right away, within an hour, easily an hour. And it's very, very telling. Keep in mind, there are other things that could cause a person to be progressively confused too, like metabolically, like if they're going into a diabetic coma, but there are lab tests for that, and some other signs and symptoms, like people going into a diabetic coma have sweating and stuff like that, heart palpitations. But this one, their lab tests, if they did them, would come back normally. And this test, which they're going to do, as soon as you see confusion, you think CT scan. See, normal. It's some sort of a sagittal. I don't think it's mid-sagittal, because if it's mid-sagittal, you wouldn't get a lateral ventricle looking like this. There wouldn't, if it was exactly in the midline, there wouldn't be a lateral ventricle. You've got to do your sagittal section out to the side enough to get. And so I assume these are comparable, and here's a little lateral ventricle and a great big lateral ventricle. And then they'd look at the third ventricle, and here's a little third ventricle, and here's a great big third ventricle, and two ballooned out, enlarged lateral ventricles, telling us that it's the aqueduct of Sylvius that's blocked. And I'd mentioned before that it would hardly ever be the drainage system from the fourth ventricle, because there are three of them. So you can lose one and you're still perfectly fine at draining that system. Also, it's not so vulnerable to injury. So if it did get blocked, it would generally be by a tumor growing in just the right spot that blocks one, but the other two will drain. Okay. And
So the fourth ventricle works fine, but it's blocked at the third.
correct. So
Okay.
the fourth ventricle does continue to drain, but it's not draining it's not draining upstream, it's only draining itself.
Got it.
And if you looked at the shape of the fourth ventricle, it would be, it could be somewhat compressed.
Mm.
Most of the pressure from the other two enlarging ventricles is kept up in the upper chamber of the brain, of the cranium. So it's not exerting that much pressure on the brainstem, except for on the midbrain itself. Yeah, there'd be pressure there. But if there was any change in the shape of the fourth ventricle at all, it would be smaller, not larger. Smaller because it's being compressed from the rest of the brain, pushing on it.
Golly. Okay, so that would be counterintuitive. You think it'd be larger, but it's smaller actually.
Well, yeah, because it's
not
actually
draining.
the reason it's not larger is it's draining just fine.
Right, it's draining fine and not getting any fluid into it.
Yeah.
So in this second MRI, where it looks like this big X, that's actually the brain on top of the skull or underneath the skull.
Yeah. Now this is a horizontal section
Uh-huh.
through, and here's the front, here's the back.
Mhm.
It's a horizontal section through the region of the lateral ventricles, just about where they drain. I mean, it's very close
Right.
to where they drain. And so it is this size at that particular level. And if you go higher or lower sections, it changes its shape. But supposedly this should be at the same level, otherwise they're not really comparable. And we see
Oh,
these very, very enlarged ventricles.
Really big.
Yeah.
Oh gosh.
Okay.
Thank you.
Let's see, the last thing, speech language, swallowing and cognition. Well, basically, we kind of went through that, but the first thing that would show up would be cognitive. And then if it continued to progress, you'd begin to see language problems. And then finally, you'd begin to see the motor problems that would impair speech and swallowing. By the time that swallowing is impaired, they're pretty advanced, but still conscious. I mean, I guess we wouldn't even be talking, if they were unconscious, we wouldn't even be talking about swallowing, but they would go through a stage where their motor speech production and swallowing would be impaired. But that's just not too long before they would lose consciousness. So
I have a question.
yeah, right.
So would their like expressive language still be intact because they would still be able to speak, but it's more like the receptive part of like not understanding what's being said? Okay.
Yeah. Okay. So we go on to number 4. Do you have time for number 4? Okay. So now, in number 4, we're taking the blood from the right atrium to the cranium, and we're doing it just with one of the flow diagrams, just like what you did. So we would start with the right cranium, and we could just do it with arrows. We don't have to really draw an anatomically correct heart at all. The way you would do it, I'll just start you out. You're going to show right atrium, arrow down, right ventricle, arrow down. Now what comes next? And I'm going to show you here. I'm going to show you this. I'm going to show you this. See, here's our right ventricle. Where's that blood going? What is that thing?
Pulmonary artery.
Pulmonary artery. Yeah. Yep. 2 pulmonary arteries. Yeah.
Okay.
Okay. Let me see if there's a better anatomically illustrated one. Pulmonary. No, I think that's good. Well, you're exactly right. It's going to go into the pulmonary artery. It's going to go, then next thing, it's going to go to the lungs. And then it's going to go back to the heart through what?
The pulmonary veins.
Pulmonary veins. Yeah, to here. Left atrium, to the left ventricle, to the aorta. Now we can talk in a little more detail about the aorta. This basically is the aorta, but it is the ascending aorta. Then the arch of the aorta. And that's all we have to go on the aorta, because the rest, the aorta continues into the descending aorta, but that's just going down to your lower body.
Okay.
Carrying a lot, it's a really big vessel, it carries a lot of blood, your lower extremities and your whole body basically, but not to your upper extremities and not to your head. So that's all we really have to go. So far, so good. Now, how far do we have to take it? Oh, up to the cranium. Okay, so now we've got it up to the arch of the aorta, and now we're going to go to a different slide. Here's the arch of the aorta, and then we've got these 3 branches off the arch of the aorta. Here's the first one, the brachiocephalic. And that is the first branch. It's a big one, and it's named as such because it's going to the arm and the head. The brachium is the arm. So it's going to the arm and the head. And so it goes only a couple inches, 2 or 3 inches. Here it is. And then it divides, that brachiocephalic artery divides into a right subclavicular, but we actually could forget about that because we're just going up to the head. So we could go from the brachiocephalic to the right common carotid. And then to the right internal carotid. And that gets it to the cranium. of course, not all the blood. It does, okay, so now we do have to go back. I'm sorry, we do have to go back to the subclavicular artery and take the right vertebral off of it and take that up to the cranium. Okay. And then we go back to the aorta. So I think that's where you kind of have to have a two-part diagram like you did. Yeah. So you can kind of divide some things. So one arrow is going to go to one arrow off of the arch of the aorta is going to go to the brachiocephalic. And then it's going to have an arrow which goes to the common carotid and the subclavicular artery. And then that's going to have an arrow which goes to the vertebral. Is anyone actually diagramming it right now?
I'm trying to follow it with words. Our little linear diagram.
Do you have a kind of those arrows going like that?
Okay, so I am at the
Yeah, well, let's go back.
right diagram into the cranium, the right atrium, right ventricle, pulmonary artery,
Good.
goes back to the lungs, and then the lungs take it back to the heart, the pulmonary veins,
Good.
the left atrium, the left
Good.
ventricle, the aorta, the ascending aorta.
Ascending aorta. That's this little segment right here. It goes up.
Okay.
And now here's the arch.
And that's what I have, the arch,
And then,
the
then-
rest to the.
then from the arch, we don't have to go down. We're just going to go off of it. And I guess 3 arrows to start. One arrow is the brachiocephalic,
Okay,
and that arrows off into a common carotid
provides into a common carotid.
and a subclavicular. Subclavian, I should call it, as I've named it here, subclavian artery.
Is that the same as the right internal carotid?
No,
Okay,
because let's go back to the common carotid. The right common
Okay.
carotid is going to branch into a external carotid artery and an internal.
okay,
Forget the external because it goes to the face and throat.
okay.
We're only concerned with the internal at this point.
Internal.
So that gets up a major part of the blood to the brain right there. But let's go back to the right subclavian and branch off a vertebral.
Okay.
And that goes up. And now that's half the blood.
Right. Vertebral.
Okay, where's the other half go? We've got to go back to the arch. And we look at the second one, which is a left common carotid. And then that branches just like the right common carotid. It branches into an external carotid, which goes for us, our purposes right now, nowhere, because we're just talking about the brain, and a right internal carotid. And now we've got up about 90% of the blood to the brain there. The only thing left is, going back to the arch again, a branch off the arch is the left subclavian, and then a branch off that, the left vertebral, and that goes up to the brain. So there's sort of 4 vessels. There are only 4, and that's how you get from the heart to the brain. The clinical significance of that is this. You say, what do we really need to know the heart for? You're going to have a lot of patients, 40% of strokes are going to be from patients who have a clot form in the heart. Most of them have atrial fibrillation. Have you guys heard of atrial fibrillation? It's very common in older people, not only older people, but mostly older people. And basically the upper chambers of their heart stop beating and start quivering. And you might think, well, don't they die right away? Isn't that like a heart? Not really, because the ventricles do most of the work. They are the ones that send the blood out. They give a good pump and send the blood to the lungs, if you're talking about the right ventricle, or to the entire body. That's really done by the left ventricle. Gives that good pump, out to the body. What are the auricles for? Just the little tiny task of getting the blood down to the ventricle. It doesn't have to go anywhere really. It goes an inch or half an inch to get the blood from the upper chamber to the lower chamber through that one little valve. It makes sense why, and literally, if you look at the thickness of the muscular wall, it's real thin. It doesn't need much strength to do that. But it does keep the blood flowing into the chamber very efficiently. And if you don't have that beat, and if you only have a fibrillation, a quiver, you'll tend to have blood that sticks around the perimeters of the chamber and doesn't really get pumped out 100%. Close to 100% because it just the vacuum effect of that lower chamber, the ventricle pumping the blood out, then it opens up and it kind of like sucks the blood down almost, but it needs just a little help to be 100%. And so with ventricular fibrillation, it's not 100%, it's a high percent. And there's enough of blood that is not pumped that it will tend to clot. You know, there are many people who have had fibrillation like that for years and they've never formed a clot. But there are many, they are at risk. And in fact, they'll say that if you have a fibrillation when it first starts is kind of off and on, then it becomes chronic. And they try to correct it when it's off and on because medicines can correct it quite well. But if they let it become chronic, it's very hard to correct it. And they'll then we'll put them on a blood thinner. So you're going to have a lot of patients who've got this condition. 40% of all strokes are caused by a clot. Where's the clot? It's always on the left side of the heart. It's always on the left side of the heart because if the clot forms in that left atrium, it's going to go to the left ventricle, and then it's going to go out by the pathway we just described. And then randomly, I mean, by chance, I don't mean randomly, but by chance, it could go anywhere in the body. It can go to the brain, it can go through the vertebral artery. It's highly likely to go through the carotid because you can see it's the very first place it could go on this right side and go up there. It's a major vessel and it's the first one. But it may not go there just by chance and go around here and go down, go to the legs or go anywhere. And so you can have what is in essence a stroke, a deprivation of blood supply to anything in the body. We're concerned with the brain because do people have, it's called ischemia in the legs? Yes, and they go to the hospital, but they don't see an SLP. You're not going to see those people. You're also not going to see the people, except coincidentally, we will, who got the clot formed on the right side of the heart. They get a pulmonary embolism. It goes to the lungs and it causes, they don't call it a stroke, they call it a pulmonary embolism. And it's ischemia. It's an area of the lung that dies because it's been deprived of blood. And it's very, very dangerous. They can easily die from a pulmonary embolism.
Yeah, I have a side note. I actually had pulmonary embolism this past summer.
Oh, did you go to the hospital?
Yeah, so I'm okay now. Like I'm on blood thinners and stuff right now.
Good. Yeah.
But it was like I had like I had two on my left lung, one on my right.
Oh wow. What
Yeah.
caused that, Riley?
It was, so I was taking a medication called Accutane for my skin.
Okay.
And then I was also taking birth control. So the combination caused it.
Okay, so it was a medication thing, not a heart.
Yeah.
Your heart's just
Yeah.
fine. Yeah.
So they like took me to the whole thing about it, like what could happen, but mine was like medication. So
Okay. Well, that's good. I'm glad it turned out well, and
Yeah.
you know the cause. Do you still have to take the blood thinners or no?
yeah, I actually have to most likely be on them permanently because they did tests and it's like a genetic thing too.
Yeah. Which one are you on?
Xarelto,
Okay.
I think.
They're
yeah.
so much better now, but they're really, really, really good.
Yeah.
And they're really very, very effective. And they tend to not have side effects. You probably don't have any side effects, do you?
No, I took one. The first one I took was like called Pradaxa. And I had really bad side effects with that one. So then they switched me.
Yeah.
So it's been a whole process, but it's finally better now.
Yeah. So we'll see. Now we see the people whose clot. Now, keep in mind when you have atrial fibrillation, it's both upper chambers that are fibrillating, not just one. So you could have a clot in either side. But if it happens to form in the right side and goes to the lungs, we're not going to get those patients. If it happens to form on the left side, we may get it if it goes up through the system we just did, and it causes a stroke, and then it can cause Broca's aphasia, or it could be in the brainstem. It could go up the vertebral artery and cause a brainstem stroke and cause a significant dysarthria or dysphagia. It could, most likely it wouldn't cause a cognitive disorder, because if it's just one stroke, your cognition is basically intact because you have two sides of your brain. You still have one intact side of the brain, in other words. So it would be an aphasia, or it could be a right hemisphere syndrome, depends where it lands. And we will see patients, we'll also see patients who do have pulmonary embolisms, but it's coincidental to what we're seeing. And then we have to, of course, take it into account because they're very sick. Yeah. Okay.
I think you're lucky, Riley, because they found it early.
Oh, yeah. Yeah, definitely.
Yeah, well, because I went, it was like a whole crazy thing, but like basically I went to the ER and they first just told me I had rib inflammation because they didn't do like a CT, but then it just like kept getting worse. So they finally, like, I finally pushed for one like a week later. Yeah, because they just were like, oh, it's just like rib pain. And I was like, I don't think so, because I couldn't breathe. So
that was a good call.
yeah.
Okay. All right. So are you going to work that out and include it, Renate?
Yeah, I have been typing, but I'm gonna have to clean it up. I've got every single.
By the way, don't be afraid to do it in handwriting with little arrows or something. That's fine.
I've got like everything you just said.
That's just fine. Little arrows and
No, I didn't write.
words.
I didn't write it nice and neat. I just right diagram into the cranium, right atrium, right ventricle, pulmonary artery, lungs, back to the heart, pulmonary veins, left atrium, left ventricle, aorta, ascending aorta, the arch of the aorta, the rest into the descending artery, but not to the head. 3 branches of the brachiocephalic artery because it goes to the arm and the head. Brachia is the arm. Then it divides into the brain, the common carotid, and the right internal carotid into the cranium.
Yep.
The blood goes to the brain, the right subclavian to the right vertebral artery. The left common carotid branches to an external carotid and to the internal carotid.
Yep.
And then I have subclavian artery to the, and then I don't know why it goes there. And then I sent
to the vertebral, to the left vertebral,
to the left vertebral.
and up to the brain.
Vertebral and up to the brain.
That's the whole thing. That's the whole system that we need to know. And then the other remaining thing is simply to be able, like we did with the CSF system, is to be able to label the parts. So here we get anatomically realistic, but I don't think we label everything here. We just labeled these things.
Got it.
Yeah. And now we're only going up to, here's a different depiction. So we don't have everything, but we do have these things. And here's the vertebral. And we're only going up to basically here. We're not, this time, we're not going beyond that. We're only getting it into the cranium. Then next time we'll go beyond.
Okay.
Okay. And so that's it.
Well, that's wonderful.
I think so. I think it makes it a lot more manageable once you can take out a piece of paper and write down what Renate's just done, and show the little arrows going, you know, up to the right and the left and everything. And it doesn't have to be, don't make it beautiful. It's just conceptual. You're just linking, you're showing the direction of blood flow into the heart and then up to the brain, and just not anatomically correct. Here's anatomically correct, see? And now we can make it a labeling task. So where are, if we look at how the body looks more realistically, where are these things that we just went through? Okay, one more. Certain metabolic signs, and this is number 5, certain metabolic problems can cause signs and symptoms that are similar to the signs and symptoms of pressure hydrocephalus. that is starting with confusion and getting worse like we did. Examples are diabetic coma and drug overdose. Describe what diagnostic tests would be used to differentiate loss of consciousness once it gets that far due to metabolic problems from pressure hydrocephalus. Well, I mean, they're going to do a bunch of lab tests, you know, tests for drugs, et cetera, but they're going to do a CT scan too. And that CT scan is going to be normal. And you don't lose your consciousness from hydrocephalus with a normal CT. So right there, that one thing, which is a very fast test to do, and they will do it, I don't want to say first, because they'll probably come take a blood draw, go do the tests on that. Meanwhile, take them to CT scan and do this, and then get this normal brain back. And they say, okay, well, it's not hydrocephalus. It's one of those other things. So that's the diagnostic process. Yeah, when somebody comes into the ER with loss of consciousness and not a very clear reason, you know, well, regardless, if they come in with loss of consciousness, they're going to do their scan, they're going to do their exam, their, you know, a clinical exam, and do it pretty quickly, but they're going to get that CT scan done in very short order, within an hour, easily within an hour. Because there are a lot of things that could cause a loss of consciousness that would be visible in that CT scan, including hydrocephalus, and would be easily diagnosed that way and would be also potentially treatable. All right.
So that's our go-to. Our CT scan will probably tell us all the information we need to know about unconsciousness.
Well, and for our patients, yes, it always does, except for one kind of stroke that we'll get to later. We're not doing it quite yet, where it's not an embolic stroke. When somebody has an embolic stroke, the one thing that shows up would be it's easy to see that their heart is in atrial fibrillation. You know, with just an EKG, or even a physician they're pretty good at listening and saying, I hear atrial fibrillation, although they're not perfect. I've seen a lot of physicians totally miss it, and seen the cardiologist say behind their back, I don't know how they don't hear that. That patient's in atrial fibrillation. But an EKG, you know, the electrical measure of the heart, easily shows it, and they will do that real fast, and it's easily done in the ER. So they'll do that. But my point is, yeah, they do those quick exams that can be started and maybe even finished in just a few minutes, and then do a CT scan anytime there's loss of consciousness. And for our patients, the CT scan would show up some things right away, but for a typical stroke where there's been a blockage someplace, it doesn't actually show up anything for 2 or 3 days, because the brain tissue still has its normal density until the tissue starts to break down 2 or 3 days later, because it's been deprived of its blood supply. And so you'll get a circle or whatever, you know, shape, big or little, that shows, oh, that area has been what they call infarcted, which is a tissue death due to loss of blood supply, and it will show up in 2 or 3 days. So the CT scan is very, very common with our patients.
Well, how do we save the patients who get stroke right away? Because I heard if you get them within 3 hours to the emergency room, they have a drug that can help.
Right, that's with a stroke like the ones we're talking about, embolic stroke, which started in the heart with a clot in the heart, or where there's been a blockage of a blood supply. Either which way, a part of the brain is deprived of blood, and there's a block someplace, and that is where they can give that drug called TPA, which breaks the clot up, but it's got to be done right away.
Yeah.
Because otherwise, what happens is the brain tissue has started to break down, and then they give them this clot, which basically is a very high-powered version of what Riley's taking, very high-powered version, you know, and it will cause them to have a hemorrhage into the area of stroke, which compounds the problem then.
Yeah.
So they have to do it within a window of time when it can actually break up the clot and restore blood supply to the tissue and restore the tissue. I've seen amazing patients who have a total hemiparesis and cannot speak, and the next morning they're normal.
That's a miracle.
It is a miracle, yeah, but only if it's. And the sad thing is that if somebody goes to bed at night and they're normal, like let's say 9 o'clock, a lot of old people go early, they go to bed at 9 o'clock. I do. And they wake up in the morning and they've got a paralysis or something, and they never got up once to go to the bathroom, and none of their loved ones can say they were okay at 5 a.m., but at 7 they weren't. See, if they could do that, as they say, he got up to go to the bathroom at 5 a.m. and then 6:30 he woke up and he can't talk. Right to the hospital, they can do the TPA. But otherwise they can't. And then the other thing that's sad and amazing too, is there are many people who will have actually a stroke and have a hemiparesis or a loss of speech, and they'll wait a few days to go to the hospital.
Amazing.
Mostly men, by the way, do that, but
Mostly men.
yeah, denial of illness and don't want to go to the doctor and it'll go away. Just hoping for the best, you know.
I hear that married men actually live longer because their wives push them to the doctor.
Yes. Yeah, something like that anyway.
Okay, so may I ask, if we have a spinal cord lesion, these don't actually cross. So if you have a dorsal,
What do you say these? What these?
So let's say I'm back to questions from chapter 2.
Okay.
So it was about, assume that the pressure from a herniated disc functionally transects each of the following structures. What do you think would be the signs and symptoms? So a dorsal root about halfway down the spinal cord. So we know that the dorsal root carries afferent information, so that it means it's coming from the senses to the brain.
And it's coming from a dermatome. It's coming from a particular dermatome too. Now you know that part.
Yes.
It's coming from that
Right.
side. So you said there's no crossing going on. There's no crossing at the levels that we've been talking about. There's no crossing of neurons on their way from a dermatome or a muscle to a spinal nerve, to a dorsal or a ventral root, to the cord. But once those pathways get into the cord, and you're considering the cord and the brain, there are levels of crossing, but we haven't done them yet.
Okay.
So of what we've studied pretty much we can say if you damage something on one side, the loss is on the same side.
Got it. So that's what I wanted to
especially when
make
you're
sure
talking
of.
about spinal nerves and dermatomes, muscles and things. We did talk about, how the motor homunculus projects down to the opposite side mostly, but not completely. So we kind of introduced some concepts of crossing,
Okay.
but we certainly haven't gotten very deeply into it.
Okay, so spinal cords don't cross, they're mostly dermatomes that
Well,
might.
no, I don't think I said it doesn't cross in the spinal cord. I said it doesn't cross before it gets to the spinal cord.
Before it gets.
Yeah, just talking about peripheral nerves or their roots, there's no crossing going on. But if you consider the total pathway of the several that we're going to consider, once you're considering the pathway as it goes up the cord and through the brain, there will be crosses.
Oh.
And they don't all cross the same. So that's why we're kind of starting where we are, because it's you don't have to think about crosses once. We don't want to start with the toughest stuff, but you've got a lot under your belt now that will really start to, help you when we get to the how the pathways work in the CNS. And we'll do that in chapter 5.
Okay.
Chapter 5 will be the sensory pathways all the way up to the postcentral gyrus. So you know the periphery now quite well. But then we're just going to connect it up to the postcentral gyrus where we do our feeling. And then in chapter 6, we'll do the same thing for the motor system, all the way from the motor homunculus down to the muscles. And again, you know the ventral root, and you know the spinal nerve, and you know it goes to the muscle, and you know that part's all on the same side. There's no crossing, but there is crossing of those systems in the CNS.
Okay. So if we had a dorsal root, spinal cord injury on the right, everything on the right side of sensory information would be distorted.
That's right. No, excuse me, say it again. Did you just say a dorsal root? A dorsal?
Okay, so if the dorsal root is halfway down the spinal cord on the right,
Okay.
so
And
it seems to me because it's going up to the brain that it wouldn't go up to the brain anymore.
well, they wouldn't. But then think, where is the loss of sensation going to be? Only where that one dorsal root came from. It's carrying neurons from where? One dermatome.
Okay.
So I forgot exactly what you said dorsal root it was, but let's just say it's the right T6. I think you said something about halfway down the body. That's halfway down the body, halfway down the thorax. So let's say there is a lesion for whatever reason of the right T6 dorsal root. There will be a loss of sensation in the T6 dermatome on that same side.
Going up to the brain and down the
Well,
body?
Where's the damage? It's in the dorsal root. And so where's the loss of sensation? It's in the
That
dermatome.
T6,
It's
okay.
in the dermatome. And then you say, well, what about the brain? Well, the brain, the
Isn't
postcentral
getting-
gyrus isn't going to get anything,
Okay,
but the pathway itself inside the CNS is intact. In other words, there's no damage there, but it's
Right.
just not getting any information
okay, so it's not.
from the one dorsal root though, from not definitely not from the lower part of the body. We're not talking about the lower part of the body. We're just talking about one dermatome.
Okay, so there would be a loss of sensation from that dermatome not getting to the brain, but would there be a loss of sensation below that dermatome?
Nope, that will all be intact. Because those dermatomes are sending their sensory neurons through the dorsal root with T7,
Uh-huh,
E8,
okay.
all of them on down. They enter, they turn up in the cord, and they go up. Remember, there's no damage in the cord, so they're going all the way up to the postcentral gyrus. It's just that one dermatome can't even get the information into the cord. And if it can't get into the cord, the dermatome is not going to be feeling anything.
Yeah, and that's not gonna feel anything, and that's not gonna send information up or down.
Because it's been disconnected.
It's been disconnected,
Been
so we're
disconnected.
stuck.
It's just like if you just go out in front of your house, I don't know if you have wires or if it's subterranean, but we have actual wires, and you just go out, and I wouldn't advise doing this, but you cut the electrical line, your house is going to go out, but all your neighbors are going to be just fine.
Got it.
And that's the equivalent to doing peripheral nerve damage.
Mm.
The line to your house is a peripheral nerve. But if you went out and you cut the big line going down the street, now everybody down the street's going to lose it. That's the equivalent to doing damage in the spinal cord.
So if we had a ventral root halfway down the spinal cord that was herniated, would we, okay, so if it was a ventral root, we know that the brain can't send things down
To what?
to that region of that dermatome. So the ventral root about halfway down the spinal cord on the left.
Okay.
So that means that the brain can't send the information down to the left side past T6.
No, what that would mean is that for let's say left T6 dermatome can feel, and so could all the other ones below.
Oh, they can feel.
Feel, yeah, because you said ventral root, so we know that's motor.
Oh, that's right.
Yeah, that doesn't interrupt sensory
Right, motor.
pathways at all. And
It
then
doesn't
since it's
interrupt.
only that one, it's going to go out to those muscles, generally around the dermatome.
Okay,
Now, there's obviously the neurologist could test the exact muscles, because if they're suspecting it's the left ventral root, T6, they know what muscles to test.
Got
And if you up here in the head, we know what muscles to test, but we don't do the body. So they know what muscles to test, and they could easily see that they can feel light tactile information or sensation in that left T6 dermatome. So they know that that pathway via the dorsal root is intact, but they can't move the muscles that get innervated by that same T6. Left T6 spinal nerve, so they know it's the ventral root. Make sense?
yes, thank you. I needed a little more clarification on that.
Yeah, it can't be the spinal nerve. It's got to be a root. It can't be the dorsal root because sensation is intact in the dermatome. It's the ventral root because they can't move the muscles that one goes to.
Thank you,
Yeah,
thank you.
it's beginning to click a little, isn't it?
Yes.
And yeah, once it clicks, I can't tell you how important that is, because you just keep it clicking.
Well,
You-
I think I'd like to be a neurologist.
It is fascinating, but
Fascinating.
but you're going to do this in SLP work.
And apply it to the people that
Yep.
I'm just gonna love working with.
Yeah, you're going to do this, except you're going to be all up here. You're
That's where I keep everything anyway.
Yeah, but you know, now I think you kind of getting a handle on how it feels to have a command of the concepts that we're dealing with, you know, today. And then you just keep that, do whatever you need to keep that going each time. Melanie, your cat's very cute.
Thanks. I don't know why she's having a whole bath right now.
It does look pretty
Trying to get her
cool.
to stop, but she won't stop.
I have to throw mine out. They want to stay on my desk and love me.
Yeah, she got up here earlier. I was like, no, you gotta go.
No, you gotta go.
As soon as I asked that question, I got to wondering if you just had one of the, digital images on your back and it includes a cat licking himself, or is it real life? It's real life.
No, yeah, that's the cat. She's having a whole bath.
I think you can get those. What do they call those? Digital backgrounds? It's not called that. You know what I mean?
Yeah, I use that. I use
And
the.
don't they have them moving? Sometimes I see the winds blowing. The trees are moving.
I have the wind and
Yeah,
the rain.
So you could have one with a cat licking himself. I like that, actually. Okay.
Thanks so much, Professor, for going
Thank
over
you.
this with
Thank
us.
you.
Okay.
Really
I'll-
appreciate it.
You're welcome. I'll post this and, later, maybe tomorrow morning, but for sure. And then we'll have one more, not this week, but next week in advance of, I think what we decided Monday would be the best, right? Right? I wrote that.
I think Tuesday.
Oh, Tuesday at 9.
Yeah.
Okay. All right.
Yeah.
Okay.
Okay, thank you so
Sounds
much.
Cool.
Thank
a
you
wonderful
very
afternoon.
much. Have a
You
great
too.
weekend.
Bye, you guys.
Bye.
Bye.
And Renata, thank you for all that hard work. You're muted, but I know what you're saying.
I plan to send it to you.
Thank you very much.
I
Okay.
plan to send it to you. Hopefully it will be corrected by you before you give it to everybody else. Thank you, sir.
Bye-bye.
Thank you. Bye-bye.